What I'm going to talk about is COVID-19 and stroke, and this is fortunately or unfortunately a much more established association and more frequent finding compared to cerebral venous thrombosis. I don't have any disclosures. You will see lots of images from Google because I'm very fond of using Google for images and the references I've cited. So this is going to be the outline for my talk. I will be talking about the relationship as we understand it today between COVID-19 and stroke. And I believe the relationship is still very much in evolution. We will discuss how acute stroke presents in patients with COVID-19, what is the incidence from already published literature, what are the risk factors, what patient characteristics we are dealing with, what are the stroke characteristics of these patients, and then what do the stroke outcomes look like compared to our other run-of-the-mill stroke. I'll discuss briefly about pathophysiology. A lot has been published with regard to pathophysiology in the past year and a half. And some very interesting insights have come for us between particularly the relationship between the infective cascade and the inflammatory cascade and the coagulation cascade. So some interesting information to share there. And then briefly, I will speak about COVID-19 and how it has impacted the stroke systems of care. So what is the relationship between stroke and COVID-19? Now, we all know that this coronavirus disease 2019 is caused by a severe acute respiratory syndrome like coronavirus, SARS-CoV-2. And we also now know that it is not just a respiratory disease and it can affect just about any other organ system, including the brain. Very early on, we started to see strokes with COVID. And a lot of data has already been published in the form of case reports as well as series, and there are better, there's registry data now that's available. But I'm going to tackle the thing in a couple of ways. So what I'm going to present to you is data that is from systematic reviews and meta-analyses, because that as we all know, is the best way to sort of judge because people have different observations on smaller sample sizes. And when we are able to pool that data, our insights are very different and much more robust. So the first, I'm going to share with you this meta-analysis where people have looked at pre-existent cerebrovascular disease and how it is leading to COVID-19 and how the COVID-19 behaves in patients who have pre-existent cerebrovascular disease. And the reviews have shown that there is an association between a past history of cerebrovascular disease, which means that somebody has had a stroke in the past or has vascular dementia in the past. And they have shown that there is an increased severity and mortality of COVID-19 in this cohort of patients. In this systematic review, 16 studies were included and close to 4,500 patient data was available. And they showed that cerebrovascular disease was associated with an increased composite poor outcome, which was almost doubling the relative risk. A subgroup analysis revealed that the cerebrovascular disease was also associated with a higher mortality. Then there was another systematic review, which was a pooled analysis of 4 studies where they showed that there was a 2.5-fold increase in the odds of severe COVID-19 in patients who had a pre-existent cerebrovascular disease. So this is one way to look at how COVID-19 can impact somebody who has a pre-existent cerebrovascular disease. The other, and for which much more data is now available, is how did COVID-19 lead to cerebrovascular disease? And again, I'm quoting another systematic review published this year, which looked at 24 observational cohort studies, and they reported that the incidence of acute cerebrovascular disease in COVID-19 patients ranged from 0.4 to 8%. So different studies had different figures, but this is the range that they were able to come up with. Across the studies, there were a total of 108,571 COVID-19 patients. And of these, ischemic or hemorrhagic strokes were found in about 1,100 patients. So then overall pooled incidence of acute cerebrovascular disease in COVID was 1.4%. Now, I think 1.4% is a fairly significant number, considering that the mortality in COVID-19 is also not that high. I mean, millions of people got it, but actually the mortality rates over a period of time have definitely shown to have come down, whether it is our better understanding or the management strategies that have changed over the year. But stroke tends to, and I will present that data, it tends to be one of those prognostic indicators which have led to this high mortality amongst patients who have COVID-19. Now, in this meta-analysis, they also looked at the pre-existing risk factors for having an acute stroke in patients who are COVID-19 positive. So if somebody gets COVID-19, what kind of risk factors are going to make them more prone to getting an acute cerebrovascular insult? And here, this pooled data showed that hypertension, a pre-existent hypertension or diabetes or coronary artery disease, and if the patient ends up with a severe COVID-19 infection, these are the people who are more likely to develop an acute stroke with their COVID infection. And you can see the odds down there, where the severity of the COVID-19 infection is very, very significantly related to developing cerebrovascular disease, as are hypertension and diabetes and a coronary artery disease. What do these strokes look like? So, I mean, are they any different from the run-of-the-mill strokes that we see? And the answer is again, yes. So the median age found in this systematic review was 65 years. There was a slight male preponderance, so 62% were males, and the vascular risk factors were, as we see most of the time, 62% were hypertensive. But diabetes seemed to be more commonly seen in this cohort. COVID symptoms at stroke onset were present in a large majority, about 84% of the patients. However, there were some, about 16%, where upfront COVID symptoms were not present and the patients were just found positive on testing. The median time from COVID symptom onset to strokes was about 9 days, and they were the reason for admission in more than a third of the patients. So, and severe COVID symptoms were present in 61%. Now, this is significant because often, I mean, with of course, the large burden of patients that we had started to see with with the pandemic, patients were not always warranted to get admitted, and our thresholds for admission, started to go down. However, whenever stroke symptoms are present, that invariably becomes a reason for admission because the chance of deterioration is fairly high in these patients. What kind of strokes were we seeing? So 87% were ischemic strokes in this systematic review, and about 11% had hemorrhages. But what was alarming is that these strokes were severe strokes. So the median NIHSS was 15, and the large vessel occlusion pattern, which always leads to more devastating strokes, was present in about 80% of the population. And in addition to that, multiple vascular territories were involved in 42.5% of the patients. And this is a big, big number, which just shows us that the COVID itself can produce a very devastating finding in terms of stroke. Now, some studies did look at, try to label the patients in terms of the etiology, and we see that the cryptogenic component went up because people were not really able to understand why these were happening. Why is there a thrombus sitting in the large vessel when the underlying vasculature is normal and then the cardiac status is normal? So cryptogenic strokes were much more commonly reported. And then some, about 10% of the patients had an underlying large vessel atherosclerotic disease, and on top of that, they had strokes. So this again is showing us that these were strokes that, I mean, we were struggling to understand the etiology of in the beginning, and now with better understanding of the pathophysiology behind these strokes, we are able to sort of put them into defined categories in terms of stroke etiology. The ICH that was seen with the COVID-19, 44% were lobar hematomas. And we'll discuss the pathophysiology, why these hemorrhages were happening in these people. Now, what was unfortunate is that the outcomes in COVID-19 patients with stroke were not good. About 31.5% in hospital mortality is reported, and a large proportion of the patients, about 25%, were actually being discharged to rehab, which means that they had large strokes and they had not recovered well from them. So again, devastating strokes, large vessel strokes, large cortical strokes, and a high mortality. So a pretty dismal picture in terms of the strokes that are happening here. Now, I'll move on to the pathophysiology of COVID-related strokes, and I'll again quote one of the systematic reviews that was published in January 2021, which is a nice summary of the available literature up until that point in time. And what they've done is they've divided the pathophysiology into 4 different categories, and I'm going to take you through these. We don't need to go into the details of how the entire cascade is sort of panning out, but what the reason for presenting this is so we have a better understanding of what kind of treatment modalities might work. Because at this point in time, we are still not sure what the best treatment for secondary prevention or for preventing a progression is in these group of patients. Will steroids work? Are antiplatelets enough? Or should we try a combination of antiplatelets and anticoagulations? So these are questions I'm hoping we could have more answers in future, and more answers perhaps from Dr. Ramani's talk towards the end of this session. So in terms of pathophysiology, we very well know that there are inflammatory mediators of ischemic stroke. And this we've known since the relationship with the influenza virus outbreaks that have, people have looked at, and how influenza outbreaks have led to an increase in stroke. There is a cytokine release by the respiratory epithelium and later by T lymphocytes when they get activated. There are inflammasomes of NLRP3. There is an inflammation-induced plaque instability that happens, and the oxidized LDL leads to further damage. So these inflammatory mediators make the vessel wall unstable, the plaque unstable, and contributes towards increased thrombosis. Then we know that the coagulatory dysfunction happens. So very early on, we started to see very high dimer levels in patients with severe COVID-19. And we found that patients who were ending up with these large vessel strokes also had very high dimers. So this is a marker of fibrinolytic shutdown. And that tells us that the fibrinolysis is not happening. So there is an increase in thrombosis. The natural anticoagulants and antiphospholipid antibodies are also, found. So Dr. Vase mentioned in CVT that there was an increase in the lupus. Very early on in case series, it had started to be reported that people were finding APLA antibodies, lupus, anticardiolipin, not on a consistent basis, but they were definitely being identified. So all initial series, 4 or 5 patients would turn out to have APLA positive. Now, whether this is a transient phenomenon that we see with viral infections or that contributed for a short duration of time to the coagulatory dysfunction is something that we are hypothesizing. Then very interestingly, there is an endotheliopathy that happens. And this, I think, is the key to sort of understanding why we see such a huge amount of damage with COVID-related infections. There is an endothelium-driven activation of the extrinsic coagulation pathway, and there's an imbalance between ACE2 inhibitors and angiotensin II receptors that leads to upregulation of the tissue factor, and we know that the tissue factor is extremely important in the extrinsic coagulation pathway. And in addition to this, there's an endothelium-driven nitrous oxide deficiency. So the vasodilatory effect is gone, and there is adhesion of platelets and leukocytes to the vessel wall with this damage. So we know that the ACE2 inhibitor is very important for this COVID-19, and it is extremely important for our endotheliopathy mechanism here in COVID-related strokes. And then we have this renin, angiotensin, aldosterone system that gets affected. And there's an ACE2 deficiency that happens. And what that leads to is an overactivity of the sympathetic nervous system. So you may see, and there's an exacerbation of the traditional stroke risk factors. So, a local increase in the blood pressure because of these mechanisms can actually lead to hemorrhages. And this is one of the suggested pathophysiology behind the hemorrhages that were being seen with these COVID-19 infections. Now, this is one of the things that I've sort of watched over time, not just in the MENA region, but also sort of how COVID-19 and stroke systems of care have been impacted. And very interestingly, we started to see some interesting articles when the pandemic started, like where have all the strokes disappeared, and things like that. And I'll show you some interesting data that we found, over a period of time, how the systems of care for acute stroke were impacted. And I think it's an important area to look at, because we're still not out of the pandemic and we don't know where this thing is heading from here. Thankfully, things are under control in most countries of the world, but it's not over till it's over. So what did we see in terms of the stroke chain of survival? We started to see that globally, physicians noted a reduced admission for stroke across the board. And they also started to see that the kind of strokes that were happening were the devastating varieties. It's not just, we sort of stopped seeing the stroke mimics. There's a nice paper that came out of Qatar, I think, where they've shown that the stroke mimics had somehow disappeared from the emergency, and the TIAs had somehow hugely reduced in number. And there are a number of hypotheses behind it. And there is some data from Egypt, which tends to suggest that people were too scared to sort of come out to the emergency. And it's quite intuitive to assume that that might have been the case. We also saw, and a number of studies have reported this, that the mean number of stroke codes dispatched to hospitals decreased. We saw the regression in the number of pre-hospital stroke diagnoses by the EMS. And we, of course, this is something that all of us faced. Hospitals were overwhelmed. Many were converted to COVID centers. My own center was converted, and we had to make huge diversions. So stroke centers, of course, across the board had to readjust to this new crisis. We saw delayed arrivals to hospitals with acute stroke services, up to 50% decrease in cases qualifying for acute intervention because of these delays. Globally, there was a median 33% decrease in stroke admissions and a 25% decrease in mechanical thrombectomy procedures during the early COVID-19 pandemic period compared to the pre-pandemic months. So this data is also published, where people have compared the pre-pandemic to the post-pandemic numbers. And then, of course, many stroke units were closed. Our staff had to be reallocated to COVID wards. There was a need for protected code stroke, which I believe Dr. Ramani might enlighten you more about. And that just delayed our procedures. The protocols had to be modified in the hospitals. Initially, we were all dealing with so much uncertainty. We didn't know how to screen the patients for COVID. Is a chest X-ray enough? We had started to incorporate a CT angio alongside the CT chest, alongside the CT angiogram for an acute stroke, just so we could sort of determine where this patient should be triaged to and what kind of intervention are we dealing with. And then, of course, sometimes you just have to stabilize the respiratory parameters before the stroke itself receives attention. So in-hospital delays were reported by a number of studies: increased door-to-needle times, reduced performances on stroke quality of care measures during the COVID-19 pandemic. And we all understand why that happened. And then the post-stroke care, of course, many stroke units were converted. So patients were allocated to stroke beds in my hospital. We didn't have the unit anymore. Inpatient care was affected because my staff had to be reallocated to COVID wards. And then, of course, the continuity of care suffered. The length of stay was prolonged, sometimes mainly for the purpose of, because the patient couldn't be shifted to a rehab center, they had to stay in the hospital till they completed their quarantine. And and the workup was seriously delayed. A lot of echoes couldn't be done because, I mean, with a COVID positive patient, we just focused on what was necessary, and these other procedures were delayed. And then the rehab, of course, suffered as well. So in summary, most reported cases are of acute ischemic stroke. ICH is less frequent. Strokes are severe. Males are affected more. Diabetes and hypertension are major risk factors. Multiple pathophysiological reasons, like I described, but coagulopathy is at the heart of most of these. We have seen unfavorable outcomes in a large majority of patients, and the mortality is quite high. Acute interventions should be attempted. I didn't present much data on the intervention part of it. We need more data regarding the outcomes with the interventions. Personal experiences, we were seeing very sticky clots with intervention, and the outcomes were, despite interventions, not very good. And we know that the stroke systems of care have been majorly impacted by the pandemic, and we're slowly trying to get back on our feet. And I thank you for your patience.